Welcome, everyone. We will get started shortly, just waiting as folks are rolling in. All right. Good morning, everyone, and welcome to today's webinar. My name is Wala Hayek, and I'm the Senior Manager of Health Equity here at Massachusetts Health and Hospital Association. I'm excited to welcome you all to the future of place-based birthing care, where we will hear from our member healthcare providers about their promising initiatives to eliminate gaps in maternal and perinatal healthcare. As many of you know, today concludes Black Maternal Health Week, and this week was founded in 2018 by Black Mamas Matter Alliance, a Black woman-led cross-sectoral alliance that builds power and advocates for Black maternal health justice. The purpose of Black Maternal Health Week is to raise awareness about the significant systemic inequities affecting Black mothers, including a long history of racism and sexism in medicine that has created many challenges and directly contributed to adverse health outcomes for Black mothers accessing reproductive and perinatal health care across the country. Over the last few years, we have increasingly seen and heard Black mothers share their stories, often sharing their struggles with finding responsive providers, receiving dignified care, and accessing wraparound support with mental health, perinatal, and postpartum care, as well as finding the appropriate community-based resources to meet their needs. In addition to facing other systemic challenges such as financial barriers, healthcare accessibility, and culturally congruent care. We also know from a growing body of research that Black mothers are between 3 and 5 times more likely to die from preventable pregnancy-related complications. They also face a higher chance of developing perinatal mood disorders, with that being one of the leading causes of complications for pregnancy and childbirth. More concerning is that they're also less likely to receive that treatment due to factors such as stigma, involvement of child welfare services, and other financial barriers. This is also the experience of many other women of color navigating our healthcare systems and trying to access care. All of these factors have contributed to a growing national maternal health crisis, a crisis that we're also facing here in the Commonwealth. A recent report by the Massachusetts Department of Public Health analyzed maternal health outcomes over a 10-year period and reported a consistent and disproportionate impact of adverse pregnancy and birthing events in Black, non-Hispanic, and Hispanic birthing people compared to their white counterparts. Black non-Hispanic birthing people have consistently had the highest severe maternal morbidity rates, with these inequities increasing an average of 10% each year. In 2011, the gap between SMM rates for Black non-Hispanic and white non-Hispanic birthing people was twofold. By 2020, the rate for Black non-Hispanic birthing people was 2.5 times higher than that of white non-Hispanic birthing people, indicating a 25% increase in the gap over time. Black non-Hispanic birthing people have not benefited from improved medical knowledge and care, said Dr. Hafsatu Diop, the Director of Division of Maternal and Child Health Research and Analysis at DPH, who's now the Assistant Commissioner for Health Equity. It's been long recognized that racism, not race, is the risk factor as it leads to discriminatory beliefs and behaviors towards Black non-Hispanic birthing people. And so on the last day of Black Maternal Health Week, we are on a mission to move past just raising awareness onto taking direct action. At MHA, we've expanded our advocacy efforts in maternal and birthing healthcare in the lead of our member hospitals and healthcare systems. Furthermore, many of our member healthcare organizations have committed to prioritizing perinatal healthcare, developing an equity strategy to address disparities in care, and implementing various community-based interventions to systematically improve Black and Brown parents' pregnancy and birthing outcomes. And so without further ado, I'm looking forward to today's presentations and panel discussions on place-based and community health models and the ways in which we can expand and sustain these programs to become part of the standard care across the Commonwealth. A few logistics before we start. If you have any questions during the webinar, please enter them into the chat as we are in listen-only mode, and so we'll be able to see questions that are put in the chat. The questions will come directly to us, and we will do our best to address as many as we can throughout the presentation and into the discussion, and then following that as well. Thank you to MHA's 2024 annual sponsors and strategic partners for supporting today's webinar, which is one of many virtual and in-person events we offer throughout the year around pressing topics in health and healthcare. And with that, I'm pleased to introduce our speakers for today, Dr. Melissa Nass and Dr. Priya Saran Gupta. Unfortunately, both Liv Norris and Dr. Jennifer Bradford were not able to make it today, but I do want to recognize both of their significant contributions to this webinar and their leadership in health justice and equity. Kicking us off will be two presentations from Dr. Melissa Nass, followed by Dr. Priya Saran Gupta about their respective organizations' perinatal programs. Dr. Melissa Nass is a pediatrician at Boston Medical Center and is the founder and medical director of Curbside Care, a novel mobile program offering comprehensive, high-touch dyadic care to mothers and babies during the first 6 weeks after delivery. Dr. Nass has special interest in adolescent medicine, reproductive health, dyadic care, and more. And with that, Dr. Nass, it's all you.
Thank you so much for that lovely introduction. I'm going to share my screen. Great. Today I'm going to talk with you a little bit about the origin and development of curbside care. And for a moment, I'm going to try to take you back to the spring of 2020 in Boston. In the spring of 2020, the city of Boston was shut down during the COVID pandemic. And for those of you who don't know Boston Medical Center, I know many of you probably do, BMC is the largest safety net hospital in New England. Our pediatric practice specifically is quite large. We have over 14,000 primary care patients in our practice. And about 80 to 90% of our patients in pediatrics are publicly insured. Our patients come from around the world, and 30 to 40% of our patients would prefer to speak a language other than English during medical appointments. And so when COVID hit the city of Boston, our patients were disproportionately affected. Our patients are essential workers. They live in congregate settings. They live in multi-generational households. And very quickly, our hospital became known as the COVID hospital. And patients were afraid to come in. And in pediatrics specifically, we saw a drop of 90% in our primary care volume. And so my boss, Eileen Costello, said, if we don't immunize these kids, we're going to have a measles pandemic on our hands by August. And so seemingly overnight, our department came into a very large, generous philanthropic donation to start a mobile program to reach pediatric patients, really specifically for immunizations. And we staffed this small mobile unit with a pediatrician, a nurse. We set it up just like an exam room. And we started providing care to our patients who could not come into the hospital, at the curb, outside their homes. And in the beginning, we were really focused on children under 5 in need of immunizations. Anybody who had missed an appointment and who hadn't come in that were young, we were going to provide primary care for them. But we were also focusing on newborns who were born to COVID-positive mothers. At that time, patients with COVID were not permitted back into the hospital. And so mothers with COVID couldn't come into the hospital with their newborns for newborn checks. And as many of you know, it's important to have the birthing parent and the primary caregiver present at those appointments. And so I went to visit one of these moms and to see her baby. And we opened the back of the ambulance dressed in full PPE in the early days of the pandemic. And the mother stood on the curb and handed her baby up to me. And we did the visit outside and inside of the back of a mobile unit. And this mother was so grateful that she just started crying. She was so grateful that we came to her during this exquisitely vulnerable period of time, postpartum with a newborn, and of course, she was quite sick. I came back to the hospital and I said to my boss, Eileen Costello, we should provide this service for all mothers, not just moms with COVID. Um, this is something that could really benefit our patients. And and many of you on this call know that the fourth trimester, the first several weeks in the postpartum period, is really a critical period of time for both the birthing person and the baby that really sets the stage for future health outcomes. And yet we know that in this period of time, there are grave inequities. While I did a beautiful job talking a little bit about some of those statistics, we know that Black birthing people have the highest maternal mortality rate, which is 3 times the rate of white women. We know that Black women have 3 times higher rates of preeclampsia and other complications in pregnancy. We know that rates of exclusive breastfeeding are lower among Black birthing people. We know that Black birthing parents are less likely to be diagnosed with peripartum mood disorders than their white peers. And we know that non-Hispanic, Black, and Indigenous infants have the highest rates of death. And so there's this very critical period of time, and one in which there are huge racial gaps. And so we started thinking, what if every time we saw the baby, we also saw the birthing parent? And many of you on this call will know that the newborn has multiple visits in the first several weeks of life. There's a newborn visit, often there's a weight check visit, sometimes there's a jaundice visit, and there's a 1-month visit. So that's 4 opportunities at baseline to reach the parent. And so what we know is that 40% of women at Boston Medical Center don't return for a postpartum visit after delivering. And this is quite consistent with national literature on publicly insured women. So we decided to go to them. And I envisioned a dyadic model. We staffed an ambulance with a nurse practitioner to see the baby and a certified nurse midwife to see the moms. And we started providing care at the curb outside their homes. And the program is quite novel in that these are visits that replace the traditional visits that both the birthing parent and the baby would typically have in the hospital with their own providers. Instead, we are having those visits on the mobile unit outside of their home, and we provide care for the first 6 weeks of life. And after 6 weeks of life, both the birthing parent and the baby go back to BMC providers in a traditional model. We can provide all of the services that we would provide in the hospital clinics. We do certainly newborn care and routine postpartum care. We can provide vaccinations. We can even provide contraception, including IUDs and Nexplanons in the back of our mobile unit. We're able to draw blood and take urine samples and do what we typically would do in the clinic. And this program continued throughout 2021 until October, when we were running out of money. I think I told you initially this programming, this mobile unit was 100% philanthropically funded, really at the height of the pandemic in Boston. But by October of 2021, patients were certainly coming back into clinic, and our funds were running out. And I was planning to shut down this program when the Boston Celtic Shamrock Foundation reached out to me. They had read an article about our program and had some money set aside for health equity work and wanted to get involved. And I'm very proud to say that they've been our partner. They are fully funding this program for a period of 3 years, and have been exceptional to work with. And so now with a commitment of some funding, we were able to really think deeply and strategically about the gaps in peripartum care in our institution. And what we did while we were building a new program off the pilot is we assembled a number of stakeholders to get their perspectives. We were able to really talk with our partners in obstetrics and in pediatrics and the NICU and labor and delivery and breastfeeding medicine and folks in the community and Vital Village and, of course, our parent advisory committee. And a couple of really important items were identified during those conversations. The first thing is we decided to provide universal care. Patients are not risk stratified in our program. We believe this should be standard of care, high touch, comprehensive, low barrier care in the peripartum period. So if you have a Boston area zip code and you get your care at Boston Medical Center, you can be in our program. The other gap we really identified in our program was lactation support. There are no lactation support systems in our outpatient obstetric or pediatric settings. And so we hired an IBCLC in our program, and we decided to practice universal touch for lactation. We said, if you are breastfeeding, if you're successfully breastfeeding, if you're thinking about breastfeeding, if you're breast milk curious, if you're pumping breast milk, you get a lactation consultation in our program. And so every patient in our program gets lactation support. The other thing we did is we hired a community wellness advocate. She recruits patients prenatally and does a comprehensive needs assessment, material needs such as food and diapers, medical appointments that need to be set up for ongoing care. We provide all those services. When our mobile unit rolls up, we come with bags of food and bags of diapers and sometimes strollers and sometimes pack and plays based upon a family's needs. And our community wellness advocate also enrolls our families in 7 different economic supports. We call that the economic bundle, and this happens in our outpatient primary care clinic in the hospital. So our patients are connected to WIC and SNAP and a variety of benefits, including a 529 plan for their infant and free tax preparation services, financial coaching, etc. And I'm very proud to say that we built into this budget training for our community wellness advocate and our program coordinator to become lactation specialists. And as of this talk, they are certified lactation consultants and are actually running a breastfeeding support group for adolescents, which I'm really thrilled about. The other thing we identified as a gap was really connection to behavioral health services. Birthing parents with peripartum mood disorders who were correctly identified in the postpartum period were taking months to get connected to care, sometimes 4 to 6 months before they could get in to see a therapist. And of course, you've really missed your window with that gap. So we created a special relationship to our colleagues in psychiatry, and patients in our program get expedited connection to a peripartum therapist within 2 weeks of identification. And that therapist provides care up through 4 to 6 months, and either the patient is discharged at that point, or there's a bridge to higher level care if there's ongoing needs. We have some things that we're currently working on. We are starting to supply donor milk on board for patients who require donor milk services. We partnered with Mother's Milk Bank of New England to be able to provide donor milk for free to our patients. We've started doing prenatal lactation education during recruitment. We have just started recruiting NICU graduates. It's an interesting patient population with some very high needs. And although they may be greater than 6 weeks of age and their birthing parent might be several weeks postpartum, we understand this is a very vulnerable period of time for both the parent, family, and infant. And so we think they could benefit from our wraparound services. And we are in the process of beginning a prenatal program. And I just want to take a moment. I know later we're going to talk a little bit about scalability and sustainability. Um, but I've been thinking a lot about what is so special about this particular model. And what I would tell you is in a traditional model, obstetrics works with a patient for 9 months. And after delivery, pediatrics begins that work again from scratch. And this is very duplicitous. OB learns about certainly the health history, the mental health history, the support systems for that family. They hear about domestic violence. They have a real sense of the family's needs. And then after delivery, we repeat all of that work in pediatrics. And in a traditional model, a mom and baby are navigating two different departments and are considered separate patients in our system. And these departments don't typically talk to each other. And in our model, in the curbside care model, the relationship to providers really begins prenatally and continues postnatal. There's great continuity of care. There's really great communication between obstetrics and pediatrics, between labor and delivery, between the NICU, between the Breastfeeding Equity Center we have at BMC, because we really understand that the mom and baby are not separated, that the health and wellness of one is intrinsically related to the health and wellness of the other. And I would argue that these values are equity driven and value based. We think that this model that prioritizes continuity, that is low barrier and provides care in the community at the doorstep is quite patient centered. It's really relationship based. And that it's value based again. Again, we reduce the duplicitous efforts between our two departments. We're really leveraging resources across the departments. And it's not a volume based program. It's a health outcomes based program. I think that the interdepartmental work has been really, really important. I think it's the interdepartmental collaboration that's been able to achieve some of those benefits that I just identified, but it hasn't been without a lot of challenges. We've had to negotiate some really some scope of practice challenges for sure, but really some infrastructure challenges. Creating an opportunity in the electronic medical record for the mom and baby to be linked from the outpatient setting prenatally to the inpatient setting for delivery and then back out to the outpatient setting was actually really challenging. Creating a schedule where we could track our providers in two different departments has been really, really challenging. And there's been some competition for volume in our programs. There was a period of time where our mobile unit required repairs, and we brought the program into the clinic, and both clinics wanted the patient volume. And so it's not without its challenges, but I think these are challenges that we have really been able to overcome. And I think really for the benefit of our patients. And so we're going to talk a little bit about scalability, but right now I am kind of dreaming about a very alternative program at Boston Medical Center for birthing parents and their infants. One that's really based on health outcomes and not on volume. And one that is continuity based. And I'm thinking of creating a team of people who care for these dyads together. And I just have been encouraging our leaders at the hospital level and our departments to think about what that might actually feel like, to share resources so that the doula that's hired in obstetrics follows the baby to pediatric appointments. or that a lactation consultant that's hired in the Department of Pediatrics actually does prenatal lactation in the prenatal setting, or that moms get their blood pressure checked when they come for a pediatric appointment. What would that feel like to us? And so it's just a little bit of dreaming that I'm doing these days. I think in the panel, we're going to talk a little bit about the limitations of this model. This is a high cost, low volume model. In part, it's low volume because of traffic in Boston. We're very dependent upon the traffic patterns and the driver and the functionality of our vehicle. And that's probably the biggest limitation to this model. Our catchment area is really Boston based, and that's because newborns require care in a very timely manner. So it is impossible to see a newborn in Brockton and a newborn in Lynn, and more than one or two patients in a day or in a session, in a morning session. And that's why our catchment area is somewhat limited. But we are really excited and we're moving forward with this work. And our next plan is, of course, to really study this model. And that is really that's really my presentation in conclusion. I think it's important to let your patients inspire opportunities for innovation. And I think it's really important to listen to your colleagues and be willing to work interdepartmentally with various stakeholders, because I think collaboration is really the key to leveraging resources for patient care. Thank you.
Thank you so much for that presentation. And I was really glad that you mentioned dreaming because I think I want to extend that to the audience, dreaming what a better and more just perinatal health system looks like and feels like. And with that, I'm excited to introduce our next presenter, Dr. Priya Saran Gupta, the medical director for community-based clinical programs at Mass General Brigham, who serves as the medical director for mobile health and special projects at the Kraft Center for Community Health. Her interests lie at the crosspoint of public health and medicine, and she uses this to inform her work as a primary care physician and an implementation science researcher. Dr. Gupta's research focuses on health disparities and the role of social determinants in disease and health. And with that, Dr. Gupta, it's all you.
Thank you. And Melissa, it's so exciting to hear about the amazing work that's happening at BMC. Our program, the program that I'm going to talk about, is just launching, so a baby compared to the program that you just heard about, literally. But I'm here to talk about our DREAM initiative, which is an initiative that's seeking to enhance maternal health, particularly within the Black and Latinx communities across the greater Boston area. And we can go to the next slide. And so just as background, and you saw some of this data in the prior presentation, we know that that Black and certain other minority populations face 2 to 3 times higher risk for maternal mortality as compared to white women. Black women are twice as likely to receive late or no prenatal care compared to white women, and that this leads to like an increased mortality rate. And though Massachusetts has one of the best healthcare systems in the country, maternal mortality rates have surged by over 136% in the past 2 decades. And across the United States, profound health disparities persist for Black people and their babies. And these disparities were more pronounced during the challenges of the COVID-19 pandemic, and worsening already because of existing barriers to healthcare access. So our program really aims to provide accessible care for birthing people who are disproportionately affected by these health disparities, and to advance maternal health equity across the greater Boston area. And our work is really, going back to the point that Dr. Nass was making at the end of her presentation, it's really informed by so many different key stakeholders. And so it's informed by patients and community members, by providers, including midwives and doctors and doulas and mental health professionals, by community partner organizations, by research and data, and also by reproductive justice principles. So we can go to the next slide. This work really seeks to reduce systemic inequities in perinatal care by offering services in a time and a location that works for birthing individuals. We strive to ensure individuals have access to essential services that are both culturally and language concordant. And we're doing this by essentially in this inaugural year of the program, launching what I think of as 3 pillars of our program, which is a 3-year pilot program that is philanthropy funded for the next 3 years. So one pillar of the program is increasing capacity for what is our Birth Partners program, which is a program that increases access to doula care and doula pairings in the perinatal period to reduce negative birth experiences and disparities. Another aspect of our program, or another pillar of our program, is this community engagement piece, where through varied initiatives, we will aim to foster spaces for community members to engage in learning about maternal health equity and postpartum wellness. And the two together inform what is our 3rd pillar of the program, which I will focus the bulk of this presentation on for the remainder of it, is the mobile postpartum care unit. So the mobile postpartum care unit is a 3-year mobile program, a pilot initiative to reduce adverse health outcomes in what we call the 4th trimester, essentially once the pregnant person gives birth. And utilizing a mobile van, we will mitigate or aim to mitigate health risks and improve overall well-being by addressing social, clinical, and mental health needs in the postpartum period by bringing care to patients' home and community, really meeting them where they are, but sort of not leaving them there through different efforts that we will focus on. So next slide. So this MPCU really emphasizes to increase access to care and reduce systemic inequities in perinatal care by offering services at a time and a location that works for birthing individuals. The pilot will adopt an iterative design process to ensure that postpartum healthcare reaches beyond the brick and mortar hospital settings, using this clinic on wheels that's DPH licensed to provide not only clinical care, but also risk reduction for all things that are relevant in the postpartum care unit. Next slide. We are essentially going to be enrolling up to 100 individuals for each year of the 3-year pilot. And we have various inclusion criteria. We too want to employ sort of a universal touch model, but in this pilot, in these pilot years, we are being a little bit intentional in making sure that we are able to really enroll individuals who are part of our target patient population so that we can test this model out as a use case and then sustain the model and scale it to be able to help all birthing individuals, as we also feel that this model has potential to become in the future what should be standard of care postpartum. So we're recruiting individuals who may be at higher risk of adverse outcomes, considering factors such as clinical conditions, social needs, birth trauma, as well as really focusing our efforts in communities that have higher numbers of individuals who cite Black as race or Hispanic for ethnicity. Just as Dr. Nass had touched upon in her presentation, just given the limitations of doing this program in an urban area like Boston, we are in these pilot years offering this program for individuals that deliver at MGH or Brigham and reside within a 5-mile radius of our hospital systems, just because it allows us to be most efficient with making sure we plan out the visits accordingly. But what's covered by that radius is all 23 neighborhoods of Boston, Brookline, Cambridge, Chelsea, Everett, Malden, Medford, Revere, and Somerville. And our outreach methods for recruiting individuals include, sort of provider-facing communications, as well as we are, for all our patients that deliver at MGH or Brigham, using a registry model to figure out who qualifies, and we'll be offering the program to individuals in that way. And then doing outreach and to different community stakeholders in case they know or hear of individuals that want to self-refer into the program. What we're seeing from our early work in this space is that there are many more individuals that sort of qualify to be part of this program than we can enroll in these pilot years. But hopefully that will further solidify our case that this should be something that's available to more individuals. Next slide. So the sort of the dose of what we'll deliver or what we'll be offering through this MPCU is up to 5 encounter visits from delivery to 6 months postpartum, concurrent with primary OB care. So our efforts will not be replacing the routine postpartum OB care that these individuals will also be offered and getting. Our services will focus on clinical care, both physical and mental health care, measures to reduce barriers like social risk mitigation, because we will have a community health worker on our team, as well as linkages to other specialized care as needed. So our van team, when they go out into the communities, will have certified nurse midwives who are supported by primary care physicians like myself for backup, as well as MFM physicians in our system, a full-time community health worker that will really help bridge the social needs that these individuals bring up, and then also licensed mental health professional. And we also are trying not to fragment any care with this effort. So as we see these patients, we will be doing regular connection back to the individual's primary OB and PCP around the care that we're involving, to really make sure that the individual's primary medical home sort of remains at the center of this, in addition to the patient. Next slide. And then we'll also be doing other things, such as, we're putting together sort of a mindful care package and resource package for individuals that we enroll, as well as participants will receive support from a dedicated team, our team, throughout their time in our program. Next. And so, like I mentioned, who can refer? Really, patients can self-refer or be referred through a clinician through our EMR, which is Epic. And then as individuals are referred, our team, our MPCU team, will sort of screen them for eligibility and enroll individuals. And then we're launching the MPCU in the 3rd week of May. And at that point, we will start enrolling individuals, but we'll be spacing out how many we enroll, so that we enroll 100 over the course of the upcoming year. And then we will start the visits. Our van will be out in the communities on Mondays and Thursdays, providing these home visits. Next slide. And then this is sort of our MPCU implementation team. Our project manager, Liv Norris, could not be here today to present with me. But as you can see, really support from many subject matter experts across our system, as well as sort of an interdisciplinary team of us that's leading this work. Next slide. And, in so many ways, we're just getting started here with so much of this work. The doula pairings for this year, we've already scaled those up with the funding that we have. We're launching the MPCU, next month. And then the community sort of events will start over the summer, with sort of 4 community engagements happening each year of the 3 years of the program. but it's so wonderful to present here. We're also open to ideas. A lot of this work is iterative. We're sort of listening and learning a lot, and trying to really make this program what we think and what our stakeholders think will be best for the communities that we're trying to serve.
Great, thank you. Thank you both for your presentations. That was really helpful and really informative. And now that we've heard a little bit about both of your programs, I'm very curious, as I'm sure the audience is, to hear from you on the future of place-based care, especially as we're seeing these mobile programs expand. They're offering different types of services across different health systems, including things like primary care, substance use, behavioral health, and healthcare, and wound care, and more. And so they've demonstrated great potential to address gaps in care, strengthen trust between providers and communities often marginalized, and also alleviating significant barriers for birthing parents and families. And so you both touched on making this a part of standard of care and having it be, Melissa, you mentioned like dreaming of a better system and what that could look like. I'm curious if you could speak a little bit about the cultural changes that needed to happen to make this happen. You spoke both about the clinical aspects and thinking about qualifications and considerations for the patient population, but what needed to happen organizationally to bring this to life?
Great. Better answers for different. Priya, do you want to start?
You're welcome to start.
Okay. Well, you sort of touched on a number of things in that question. I think that this work is really exciting, and one of the things that I think both Priya and I talked a little bit about is that you don't want to separate patients from their medical home, right? We do think that the medical home and coordinated care is the best way to provide primary care, at least, and these. And so these models have to have a real relationship to the medical home. What's unfortunate is that the medical home is difficult to navigate. And what's difficult, what the medical home doesn't always provide continuity of care. And so thinking about what values our programs bring to patients that are easy to replicate in a traditional model or within the hospital walls or within the medical home is part of what I'm doing to sort of reimagine things. And I think I touched a little bit on how difficult we have infrastructure that really keeps us in silos. And it's been difficult to navigate that infrastructure, to really coordinate care across departments. And, some of any of the family physicians on this call are going to say, guess what? We've been doing this for 100 years. This is our model. You don't have to put two providers on a van. Actually, one person can do this work. And they're right. They're right. This is novel programming between obstetrics and pediatrics, where we don't talk to each other the way we really could and should. And even in the family medicine model, if we talked with our colleagues, they would identify a number of different gaps and infrastructural challenges to dyadic care as well. And then you asked a little bit about organizationally what it took to make this happen. This is like grassroots effort. I have like a program, but we just put a bunch of names on at the end of her presentation. I have a program coordinator. And then I have my clinical team who provides patient care. And it's been a lot of challenge organizing within the hospital setting. We are just now starting to attract the attention. We've been functioning for a full year with the new Celtics funding. We just celebrated our 1-year anniversary of this curbside care program. We had the pilot during the pandemic, but this is year one. We are just really starting to attract the attention of our value-based care teams and our population health teams and our health equity accelerator team and our community engagement team, those all exist in the hospital. But this program really kind of is like bottom up peds and OB meeting the needs of their patients. And I'm really excited to start engaging with folks who are aligned with strategy in the hospital setting organizationally. I think that's our next. We need to be more fully integrated strategically.
Yeah, so well, I can start by saying yes, this is also very much a grassroots effort. I did put up a whole bunch of names on that slide, but I think that is mostly to show that part of how we've gotten momentum in our system to do this work is by literally reaching out to everyone and anyone and bringing people on as subject matter experts to help inform this work, because I think for too long, maybe community health has existed in sort of silos and in many spaces in healthcare. And what we're realizing and what and I'm grateful for my leadership for being so behind this, is that if we sort of come together and break down some of those silos, we can actually truly be more impactful in community health and really shift that focus from just doing outreach to really doing work that improves health outcomes. But to be able to do that work that improves health outcomes, and health outcomes that often span, multiple, quote unquote, disciplines, you need to work together. And so, I always say a big part of, with this work and other, mobile community work is reaching and including, internal and external key stakeholders, and that community engagement, that engagement piece is a big part of the role that I've played in this work, and that my team members have played, that have actually allowed us to design something that's really co-designed. Every time I'm talking to somebody in this space, I'm learning something that maybe we didn't think of, or something that we could do a little bit better. And I think that's so much a part of it. And I'm almost forgetting the earlier part of your questions, but in terms of I think you were about how the institutional piece, I think it really goes back to what Dr. Nass was saying around sort of the working in silos. But now that there's this momentum to sort of work together, we're able to do some of this work in a way that's garnering a little bit more support for it. So I think that's been a big part of it. And I think that the COVID pandemic really highlighted sort of that importance that, I'm a family physician. During my training at Brown in Rhode Island, we were doing some of this in its own ways, like 10 years ago when I was training. And so in that sense, it's not new work, but I think that that appreciation around how social determinants or social risk factors really play into health really came to the forefront during the COVID-19 pandemic, and sort of harnessing what we learned from that into these other spaces where we have these like health disparities that have existed for years and years, but in this day and age really shouldn't exist, and things that we have solutions for is what we're trying to do now, in Massachusetts with some of this place-based efforts and so much other effort that's going on in our in our larger community and in healthcare.
Thank you both for that. And you both touched on breaking down silos and the importance of having collaboration and just different clinical disciplines involved in this work. What are some of the ways that, you're formalizing some of these relationships in this program to be part of now the larger culture of the institution, and to both of your points, making this a standard of care?
I can go first. So I think one way that we're really trying to build in a little bit of like some method around some of the engagement that we're doing. I think too often, maybe in medicine, as especially as we're serving those individuals that live in historically marginalized communities where there is this mistrust, where people don't always understand our intention or why we're there. We haven't maybe listened and learned in the same way that we're trying to do now. We're trying to have really closer connection to even the community organizations that have a really good rapport in the communities that we're trying to help. We're trying to work more closely with our partner institutions, and some of those institutions have had a much greater presence in the community health space, and trying to learn from them on how to do this work in a way that's effective and culturally concordant. And then I think the final way that I know with some of our programs here at Mass General Brigham is really trying to bring in teams and workforce to help us do the work that is from the communities that we're trying to serve, folks that speak the language, that know the culture, and even with some of our community engagement efforts, giving members of our team that have special connections with those communities be sort of the face of the work is a big part of our effort.
I don't know that I have a lot more to add, except that I could echo most of what Priya just said. I think that creating a culture of inclusion is really, really important, and our team, myself, I just try to be accessible to whoever wants to engage. Priya called me like a year ago, I don't know, 2 years ago, maybe now. And of course we got on the phone to talk about how we can care for the same patients. I mean, because that's the right thing to do. And so I think I get calls from all over. I get calls from different people in different parts of the country wanting to do this work. And I think being accessible and being inclusive and including diverse voices in the conversation is really a way to bring people on board, and at all levels, interdepartmentally, between clinicians and administrators, between folks in the community, between other people who are doing the same stuff. I just there's no real room for exclusion or competition because we're mission based here.
Thank you. That's really important, and I definitely appreciate both of you touching on needing to hire folks and include folks from the communities that we're serving, because ultimately, they know their communities the best. So you touched a little bit on collaboration, continuation, and thinking about expanding these and scaling up these kinds of programs, which requires sustainability and a plan to, have it be not philanthropy based forever. And so what are some of the ways that you think that there's opportunities to expand, payment methodologies, to make these sustainable programs, to scale them up, to make them more accessible to more communities?
I think that is the crux of the biscuit. I think that is like a great question that you're asking. The first piece, which someone in the chat mentioned, is really evaluation of the program. I think that we have to show that this kind of work, which is high cost and low volume, is really affecting change the way we hope to regarding health outcomes. Are we keeping patients out of the ER? Are we reducing readmissions? Are we really providing a patient-centered care that works for the patient in their community in an improved way than the hospital care we're providing, the care we're providing in the hospital? I mean, there's so many questions that we can ask. Are people breastfeeding for love? I mean, we could just keep asking questions. So I think that's the very first step, and we're beginning that process now. And then I think that alignment with certainly at BMC, alignment with hospital strategy as it relates to ACO priorities is really important. We're trying to think creatively about how we could use the mobile unit during off hours to make it more profitable. Um, Certainly, changing the encatchment area might change volume. Um, Putting one provider on the unit instead of two would also change cost. There are some variables that we can tweak, but the very first thing that we really need to do is evaluate the program.
Yeah, no, I'm building on that. I mean, we're just getting started with Dream, but another sort of mobile program that I oversee is the Mass General Brigham Community Care Vans, which have been around for 3 years. And on those vans, our care focuses on hypertension and diabetes and substance use disorder care. But so we've done a lot of thinking around sort of, you know, how can we keep ourselves sustainable? And I think big picture wise, I always come back to two things. Like, so one is, I think one piece of the sustainability model is securing, I mean, it all comes back to funding, but, doing visits when you're going to the clinical space, when there are opportunities where you can bill without it affecting the patients, but sort of leveraging for those individuals that have health insurance, like leveraging that health insurance piece, I think does help contribute a little bit to the sustainability. It also introduces a whole lot of other things that you have to also be mindful of, like making sure then those individuals like have the health insurance and things like that. I think that whole piece is a little bit different when you're talking about seeing all comers for something like a blood pressure visit versus, moms and babies right after they've delivered. I think the other piece, though, like eventually, what really will inform sustainability, or a big part of it, is like Melissa mentioned, we want to evaluate our efforts. We want to show that change in health outcomes. We want to be able to show maybe how many healthcare dollars are saved by people not ending up in the emergency room for things that could have been avoided. And then really make a case towards changing policy, right? Policy and reimbursement. I think eventually that's where we have to head. But you need sort of the data. You need voices behind that kind of advocacy to be successful. And so I think that's sort of in my mind, when I think of like a big picture map on how these efforts can be sustainable, that's what comes to mind.
You touched on my next question actually, which was going to be, what are some of the lessons learned in policy to-dos that we should be thinking about? We all know policy change takes a while, and I think, part of the healthcare community's efforts is to really start thinking about, dreaming what a better system is, to use Melissa's words again. And so what are some of the things that we can start thinking about in terms of system change, big picture, like policy, advocacy initiatives, that we can start thinking about as a community, and really start to think about solutions to address this in the long term?
I mean, I can start with that in sort of like a softer way. So I mean, I think one of the things when I think about some of the work that we're doing in community health, and I think about community and sort of, if we just go really back to the basics, and I see this as a primary care physician, but also just like a human living in this world, that, everybody needs the sense of belonging and community. And I think where we see that come even to be even more true is when individuals are going through something in life where they're vulnerable. And certainly this period of, postpartum period or during pregnancy, you have these birthing people that are in one of the most vulnerable positions in their lifetime, and they need community. And I think what's often lost in our healthcare system is that we get so focused on, sort of the biological things that are happening with someone's health that piece is lost. And so, you look at sort of postpartum support globally, and the ways in which people, birthing individuals are supported in society, in other cultures, in other countries. And, in this country where we are supposedly providing world-class healthcare, we're sort of missing the mark when it comes to postpartum care. And so I think like almost going back to that piece and starting there, I think, and because I imagine that so many times when we're presenting policy, like many of those individuals have been parents or have been in this journey, and I think maybe starting there might be a good place. And then, of course, then backing that up by data that just shouldn't really be data that we're dealing with right now, right? When you think about maternal mortality and why, like why the rates are what they are and things like that is another good place to start.
Yeah, Priya, that was a really great answer to a question I think is really difficult to answer. And I think that I can't speak to any specific policies. I do know that this kind of work um, is not a big moneymaker, like, and probably won't be. Caring for women and babies has never been um, something that's very lucrative. And so I think that it involves a shift in values as we consider policy. And that's why I think health outcome driven work is so important. The statistics that you just rattled off are mind blowing, and I think a real shift in priorities and in values at all levels is really really what's necessary.
Great. Thank you both. Very much appreciate the shift in values and thinking about prioritization. So definitely good to keep in mind. And with that, I want to open up questions to any of our audience members. If you want to put a question in the chat for any of our panelists, please do so. We have some time for that.
Great. And I just saw a really lovely comment from Matthew Venno, which sounds like he's a BMC guy, and I'm really thrilled. And I got my start at BMC in the mid 90s, and I kind of came of age there, and was there when Reach Out and Read was kind of getting off the ground. And it's nice to see a friendly face kind of chat.
Well, thank you both, and hopefully we can have you sometime soon to hear about evaluation processes and where this program is growing. I wanted to echo our thanks for your time today and for your leadership, and thank you to everyone who's joined us for today's webinar. Please feel free to reach out to any of us with any questions. And again, we have several events this spring with our MHA educational programming. For more information, please visit or scan the QR code on the screen. And thank you again all. So we will follow up with materials on the slides that our presenters share today. And we look forward to seeing you all again soon. Thank you. Have a wonderful afternoon.